Hi, welcome everybody to FDN's Lab and Learn with Reed Davis, the founder, and of course our science officer, Dr. Aaron Gonshor, who's really looking forward to a presentation today on the stress and hormone profile. And I want to tell you the first test I ever ran way back when in the office, we were seeing all kinds of people coming in for all kinds of problems, and I always ran the stress and hormone profile. Why? Because it tells you the effects of stress, the sort of long-term damage being done. At least it's one window into what's really going on with a person. And at the time, and I'll make this short, but at the time, I wasn't diagnosing and treating anything, just looking for what was really wrong with people who, again, they'd been to doctors, multiple doctors sometimes, nothing against doctors, but they were still searching for answers. And so they came to us at our kind of alternative clinic for what's really wrong. And this is one of the featured tests, and I can't wait for Dr. Gonshor to go over it. So thank you, Dr. Gonshor.
Well, thank you very, very much, Reed. Please call me Aaron. I will tell you that you're absolutely right, and it has been a fundamental test for us as it is for you. And there's good reason. I'm going to try to deal with that. I should say that the next 2 to 3 sessions are going to be on this stress and hormone profile, simply because it does give you so much information. So we said we're not going to spend a lot of time on this, so let's look at this. And we're calling this the advanced stress and hormone profile. And the reason for that is that this particular profile, and to the right, you can see all the different things that are on a typical report. And on the left, you see what it's actually dealing with. And it's quite dramatic. I mean, you have the stress profile, which is looking at adrenal function, cortisol, DHEAS, etc. The female and the male hormone profile, which you also see, estradiol, progesterone, testosterone, extremely important. We look at melatonin and the whole idea of circadian rhythm. The immune profile, at least the mucosal immune profile, as concerns secretory IgA, SIG-A, an extremely important part of the immune system, which we will be going over at a separate session. And last but not least, the metabolic profile, which if one were to order the advanced stress and hormone profile, it gives you everything we've just discussed. And of course, added to that, insulin. And with insulin, both the fasting and non-fasting, it gives you an idea of where that person is in terms of their metabolic profile. Remember, these are all screening tests. They're non-diagnostic, but it gives you a very, very wonderful open window on what's going on. And I think the other thing that you need to understand before we get into the first part is that they each interact with each other and have effects on each other. And I think that's what makes it so important. So always keep that in mind. It's not just a whole series of tests that are completely separate and have no relationship to each other. Nothing could be further from the truth. They're actually all very related. And so let's look into this. And the first thing we're going to just remind you is that this is a saliva test. And because it's a saliva test, what we're looking at here are the free steroids, which represent, by the way, only about 2 or 3% of the steroids that are produced in the various parts of the body. Let's say in this case, today we're going to be discussing the adrenals. So the adrenals produce a lot of hormones, but most of those hormones are bound up immediately. As soon as they get into blood, they are bound up with albumin. These are all proteins. Albumin, which is nonspecific. SHBG, which is a sex hormone binding globulin, a protein, binds estrogen, androgens. CBG, cortisol binding globulin, which binds cortisol and also progesterone. So when you're looking at it in blood, you're really not getting an idea of how much that steroid is available at that moment in time to the body. It's really only when you get into saliva and to certain urine tests that you're able to actually understand what is really going on with the free, or what's called bioavailable component. And that's really what we're discussing today. And just very quickly for you to remember that this is the adrenal. The adrenals actually sit on top of the kidneys. And in the adrenal, there are a whole series of different zones or zonas. And the ones that we're going to be dealing with mostly are the ones which lie in the cortex. The cortex is the outer layer and is really a combination of what's called the zona glomerulosa and the zona fasciculata and the zona reticularis. So it's only this area, which is the cortex. The medulla, the inner portion, is for a whole series of other types of hormones. So the cortex, sorry about that, the cortex is really the one we're looking at. We're going to be looking at cortisol. We're going to be looking at DHEA today. And just a reminder, which is really important, that when you start with pregnenolone, which comes from cortisol, it can form a whole number of things. One of the first things that it forms is DHEA, which we all are aware of. And DHEA then is able to form a whole series of things, including testosterone, the male, the androgen hormone. It forms estradiol, in other words, the female hormones. And pregnenolone is also able to produce progesterone, which then forms cortisol. So there is a interrelationship of all of these hormones that we're going to be discussing. And so today, we're really going to be looking at cortisol. In fact, cortisol diurnally, meaning 4 cortisols during the day, extremely important. And we're going to be looking at DHEA in its sulfated form. And I'll go over that in a moment and what the differences are. That's what we're going to be discussing today. And so let's take a look at cortisol. And this is a very busy slide, and it's meant to be, because what it's saying to you is cortisol is not just the stress hormone, which is very important, but it's not just that. It's not just the anti-inflammatory hormone, but in fact is involved in almost all aspects of systemic function. And you really need to remind yourself of that. Cortisol is omnipresent. It's present in all of the different systems. And I just made a red circle around a couple of these. For example, in the mucoskeletal system, it's part of the muscle catabolism and anabolism, and we're going to go over that in a minute. In metabolism, of course, the same thing. In the area of the integument, the skin, the epithelial layers, wound healing, it's anti-inflammatory. So it's really involved in so many different things. Well, okay, so what are some of those signs and symptoms of high cortisol? What if you have high cortisol? Just to give you a quick idea, you're going to see weight gain in the abdomen, in the stomach, in the upper neck areas, in the round puffy faces. You've all seen people with that. You're going to have high blood sugar, which is going to affect thirst. And by the way, today is just an overview. We're doing it at 30,000 feet, passing over this. We can do a couple of hours on each one of these, and they deserve a couple of hours. But today we're just going over it quickly. So with high blood sugar, excess thirst, excess hunger, there's a craving for carbohydrates. You're urinating frequently because of its effect on aldosterone and so on. Sexual dysfunction, very important. And a lot of people don't realize that. It can create irregular menstrual cycles. You can have fertility problems, of course, decreased libido, erectile dysfunction, all of these issues. Neurologically, extremely important, especially when it comes to not just cortisol, but DHEA. We'll go over that in a minute. Depression, panic attacks, etc. In the skin, a whole number of issues which you will actually see if you see a person who's suffering from high cortisol. The stretch marks, especially on the sides of the abdomen, very thin skin. You'll see people who bruise easily. Of course, the increased hair growth in females, etc. In the bone and muscles, high cortisol can cause some very tragic and disastrous issue for aging, those who are aging, where you see osteoporosis and fracture, etc. The immune system, extremely important. High cortisol is going to increase the infection susceptibility, and it's going to decrease the ability to heal after you have wounds. That's an extremely important thing. High blood pressure for any number of reasons, and of course, sleep problems. A lot of people with high cortisol are waking in the mid period of their sleep and therefore have fatigue. And it's not due to apnea in this case, but due to high cortisol. In general, they have less stress tolerance. They have increased inflammation because cortisol is really dysregulating all of this. I'm not going to spend a lot of time on this. I just mentioned a little bit, but I'm sure all of you have seen, and some of you may be suffering from some of these issues, which is excess cortisol and its effect on tissues. The buffalo hump, the classic buffalo hump, truncal obesity with those stretch marks that I talked about, osteoporosis, the thin skin that I mentioned earlier, the classic moon face, and that's what it's been called, the moon face, together with those red cheeks. Looks like somebody has just come out of a shower where they have the red cheeks. Very thinning hair, and yet in women, you will see facial hair, especially in the area of the mandible, the lower jaw, and just underneath the area of the mandible. Hyperglycemia, and I can't stress enough that you are going to have high sugar levels, because that implicates many issues, and not just diabetes and hypertension, even those are extremely important. Greater risk of various kinds of cardiovascular issues. I told you about the vulnerability to infection, etc. So all of that is extremely important. I also want to make mention of the fact that there is this yin and yang with cortisol and melatonin. And remember I told you all of these profiles affect each other. Melatonin, the black, it is at its highest peak in the middle of the night. That's what's bringing you to be able to sleep and to get through the first stage, even the second stage of the 4 stages of sleep. But that's also the time when cortisol is at its lowest, but starting to come up. It's starting to build. And then by the morning, it is at its height, whereas melatonin has already dropped. So cortisol is very high in the morning. Melatonin, the diamonds, has dropped. If any of these are out of whack, it's going to affect the other one. That's what you need to remember here. We're going to go over that in detail. Very quickly, remember that normal cortisol goes through a diurnal, meaning a daily rhythm, which is quite apparent. The morning cortisol, which you see here, very high. It's normally taken about 30 minutes after you get up. You normally shouldn't be taking it before then. That's when you're going to see your highest level. And then it drops, normally during the day, for all kinds of reasons. Now, there is what's called CAR, which is a cortisol awakening response. That means when you wake, it takes you 15 to 20 to 30 minutes to reach your height of cortisol. I'm not going to speak more about that, but if somebody asks us about it, I'll tell you why that's a problem issue for testing. And just very quickly, we're not going to spend a lot of time on this. You can have elevated cortisols, both absolute and relative. So when you're looking at a morning value, you can have an absolute height. In other words, it's going way above where it should be. The green area is where it should be. And so it's going to completely go out of that area. And that is normally due to very high blood sugar levels, insulin issues, etc. Again, how does cortisol and insulin come together? Here's another way it does. or it can be relative. In other words, the the cortisol level in the morning is still within the normal parameter, but then during the rest of the day, it just goes off a cliff. It drops completely. Why? Why is it doing that? That is something you need to be able to determine. And I just want you to remember that cortisol can have a loss of that diurnal rhythm. So we talked about it being high in the morning and then goes down gradually during the day. Well, if you have hypercortisol, there is no diurnal decrease because it's always being stressed. It's an active stressor at that point. People with Cushing syndrome, that means too much cortisol is being produced in the adrenals, are just not able to decrease those levels. You can have an unbalanced pattern, starts high, goes down low, and then oops, in the evening, it's going up again quite high. That is quite often due to depression. And if that happens, it's going to cause sleep disturbance. Remember, I told you about the cortisol and melatonin. If cortisol is very high, it's not going to allow the melatonin to do what it needs to do during the early to late evening to allow you to go to sleep properly. And people, of course, with hypocortisol are going to have what used to be called flatline, almost no level of cortisol to speak to. That can be due to an HPA axis, the brain not being able to respond properly during sleep. And of course, those with Addison's disease. And Addison's disease is just the opposite of Cushing's. Addison's is an inability of the adrenals to actually create cortisol. I'm just going to go quickly through DHEA, or the sulfated form, and I just want to remind you about DHEA. So it's primarily from the adrenal glands. Remember, I told you it's produced in the cortical or cortex area, of the adrenals. And then it starts there, but additional production of this substrate, DHEA is a substrate, allowing other hormones to be formed. Those other hormones are then performed in other parts of the body. So the adrenals produce a DHEA, and then in men, in the gonads, you're going to produce testosterone. You're going to produce the female hormones mostly in the follicles of the ovaries, etc. DHEA does not stay stable throughout life. In fact, it goes down dramatically when you're going from the 20s to the age of 70 and greater. And that's very important because that begins to affect age-related diseases, cognitive decline, osteoporosis, etc. And the result of these decreases is in fact a decreased capacity of the sex hormones to protect brain function. What do you mean by that, Dr. Gonshor? Well, the sex hormones have many different functions, and one of them is to protect the brain. I'm going to repeat that. These hormones protect the brain. It's not just reproductive issues, but in order for them to act properly, cortisol and DHEA should not be unbalanced. And if they are, it's going to cause a problem. So the brain has greater susceptibility to various neurotoxic effects of cortisol. So DHEA needs to be there to counter what would happen with high cortisol levels when you're talking about brain function. And by the way, DHEA quite often is given to female and male patients. Why? Because, as I mentioned a little earlier, you're looking at symptoms, low androgens in combination with low DHEA, etc. You're trying to counter that. That's one of the major reasons for supplementation. So very quickly, a reminder, cholesterol, of course, produces all of this. It starts with pregnenolone. It used to be known years ago as the mother hormone, which can form progesterone, etc., to go to cortisol. But in this case, we're talking about pregnenolone forming DHEA, And DHEA can be sulfated to DHEAS, but DHEA is the precursor, meaning it's the substrate from which you then form all these beautiful hormones, testosterone, which then forms DHT, etc., or can form estrogens, estriol, estradiol, all the things that we love. So, sulfation, why do we test for the sulfated form? Because the sulfated form facilitates DHEA transport and excretion, and is also able to alter the biological activity, its availability. In fact, DHES is what is really coursing through the body and doing most of the functions. Even though we always talk about DHEA, it's really the sulfated form that is important. And that is what we do when we call it the vital precursors. It's both DHEA and its sulfated form. And just a reminder again, the conversion of DHEA into all of these other hormones takes place outside the adrenals. And just very quickly, DHEA and its sulfated form have very large clinical significance, which makes it very good as a biomarker and for various therapeutic targets. In neuropsychiatric disorders, I mentioned earlier its effect on the brain, and there is a potential therapeutic role for DHEA supplementation for those who really know how to follow it properly. Endocrine disorders, I mentioned that earlier. Of course, if you have adrenal insufficiency, then all of these different hormones are not being produced sufficiently. So you can get resulting low DHEA and DHEAS. So it's a valuable biomarker for HPA axis assessment, meaning what is the brain's effect? HPA is the hypothalamus pituitary adrenal axis. So the adrenals are affected by the brain's action, and you need to be aware of that. We do know that DHES is given to females, male patients, for any number of symptoms that are related to low androgens, etc. Excuse me. I mentioned aging before, and I just want everybody to be aware that the decline in DHEA and DHEAS has tremendous potential as a biomarker of aging. And DHEA supplementation throughout the world, by the way, it's one of the supplements that's given in great amounts, and because it has positive effects on various age-related changes. And I mentioned that earlier: cognitive, muscle strength, bone health, immune function, remember brain function as well. And last but not least, it is a biomarker which can look at risk of cancer, especially for premenopausal breast cancer. And I want everyone to note that there is a positive association for estrogen receptor positive and progesterone receptor positive tumors in those over 45 years old, and also with DHEA problems. Very active area of research. So let me just complete this by very quickly going over why would you want to look at these adrenal stress profiles. Well, I think it becomes clear from everything I've said. You want to look at stress issues, fatigue, someone with low energy. You would also be evaluating their levels of thyroid and of iron. We can discuss that at a separate session. The abdominal weight gain, how much of that is due to adrenal imbalance? The sleep disturbances, the anxiety and depression, quite often due to that, and the blood sugar imbalances. So there are many stressors. Emotional and mental, you've got sympathetic hyperstimulation. That also comes from the adrenals, a different part, from the medullary part of the adrenals. The metabolic and glycemic dysregulation, if that's unbalanced, you're going to get increases in glucose production at the same time that there's insulin resistance. So you're going to get hyperglucose levels in the blood. Chronic inflammation and pain, those with inflammatory bowel disease, food allergies, joint issues, etc. And those with sleep disorders, especially obstructive sleep apnea, they are going to have an increase in this HPA axis. That's the brain talking to the adrenals. And what it does is it increases adrenocorticotropic hormone. That means the brain tells the adrenals to increase more of all of these different hormones that it works on. And what's the result of that? Well, one of the major things is an increase in cortisol release by the adrenals. So there is a very important aspect to this. Another thing that you need to remember, because we're going over this very quickly, just to remind you of some of these things. Normally, remember that pregnenolone produces both cortisol and DHEA. If things are normal, it's okay. But you can start going into the classic stage 1 progression of problems. And what happens in stage 1? Cortisol is overproduced. In fact, it spikes dramatically. Remember, Judah, insulin issues, any number of these things. DHEA, on the other hand, starts to go down, and pregnenolone slowly begins to go down. If you don't deal with it at that point, it goes to stage 2. And by the way, as I say here, the time of each of these can be highly variable, but stage 2 can last a number of months or several years, and that's when all the things begin to go down. The adrenals say, I can't continue increasing cortisol production. I've had it. And that's not the worst of it. The worst of it is you go to stage 3, where everything now is failing. There's still some, but it can still go even worse, and that is total failure. You do not want to be anywhere near there. So if you're looking at an adrenal stress index, the stress will tell the hypothalamus and pituitary to get the adrenals to start affecting the amount of cortisol and DHEA that is being produced. And it's that ratio which becomes important in terms of all of these different functions which you see here. But what I want to concentrate on in the last 5 minutes is, what is cortisol and why is it called a catabolic hormone? It has catabolic function. What does catabolic mean? It mobilizes the creation of glucose, fatty acids, and amino acids, which is just the opposite from DHEA, which is an anabolic steroid. It has anabolic function. It's the anti-stress hormone. What does it do? It's providing, as I said earlier, the substrates to create, for example, all the more potent androgens and estrogens for protein synthesis, anabolism in general, allowing muscle growth and strength. Well, okay, so what is a catabolic reaction? What is it really? Well, you take in foods, and those foods get broken down from the large proteins, complex carbohydrates, triglycerides. They get broken down into the simpler ones, amino acids, glucose, and the fatty acids. And 40% of that breakdown is to create, why is it doing it? It's to create energy. It's to create ATP, adenosine triphosphate. That's what you need. The mitochondria are doing that. Without that, frankly, you're dead. So it needs to be able to do that. But it can't just continue doing catabolic. There needs to be a building block which says, you know what? When I've broken it down, I also need to rebuild some of that, because otherwise the breakdown, if it's one way, that one-way street is going to be eventual demise. So even though you have amino acids, if they're not immediately needed, they immediately start forming proteins again. And glucose is going to start getting back to its more complex forms, etc. So anabolic reactions is just the opposite. It's the joining of the smaller molecules into larger ones. So it's getting monosaccharides to poly, the complex ones, fatty acids back to triglycerides, amino acids back to proteins. and nucleotides back to nucleic acids. These processes require energy. So the ATP molecules, which are generated by catabolic reactions, are needed for anabolism to occur. So the two of those have to work in consort. You can't have too much catabolism and anabolism if you want balance. And the problems occur when that becomes unbalanced. In the case of regulation of metabolism, remember, catabolic hormones stimulate the breakdown of molecules in order to get energy production. So what are those? That's cortisol, glucagon, etc. Anabolic hormones, they synthesize molecules. Growth hormone, insulin-like growth factor, insulin, which we're all familiar with, testosterone. Here we go again. This is not just reproductive issues. You need testosterone and estrogen to synthesize molecules for muscle strength and bone strength. You ask any aging male who's had to undergo treatment where they decrease testosterone, ask that male what has happened to their muscle and bone function. This is just something that, if you would like, I can give this to you. It's a breakdown of each one of these and what are their catabolic or anabolic functions. And to sort of finish this off, the cortisol to DHEA ratio, which we give as well, is an indicator of everything I've just discussed. Chronic stress increases pregnenolone in the adrenals, which produces overproduction of cortisol, mostly underproduction of DHEA, which then affects the sex hormones. And that's going to elevate the ratio. Why? Because there's more cortisol. It's the numerator to DHEA, which is the denominator. And that's what helps you identify the dysfunction. And if the ratio is high, you've got adrenal dysfunction. Last but not least, just remember, what is the relationship of stress to IBS, to gut function? And remember, we'll be discussing secretory IgA in a separate session. If you've got chronic stress, the brain, which is networking with the gut, is going to say to the gut nervous system, that's called the enteric nervous system, there's a problem here, and I want you to act accordingly. So if you've got a lot of anger, if there's anxiety, there's panic, the brain sends signals and it triggers gut symptoms. And if those are being signaled constantly, completely unbalanced, then it is one of the primary drivers of what is known as irritable bowel syndrome. Remember, irritable bowel syndrome is not chronic bowel inflammatory problems. It's a syndrome which quite often is not starting or even exists necessarily primarily in the bowel, but is being caused outside of the bowel. That's the difference. Stress and infection, well, if you've got chronic stress, there's adrenal hypersecretion. And what it does is it suppresses, remember the yin and yang, increased adrenal secretion, decreased immune system. What does that do? Well, we know it increases your susceptibility to infection and to disease. So you're much more vulnerable to both of those. That's all I'm going to say on that factor. And the next time around, we're going to be discussing not cortisol and DHEA, but we're going to be discussing the sex hormones as well as melatonin.
Well, Aaron, that was amazing. I'm very envious of the way you delivered so much information in such a short period of time. It was incredible for someone who's run a few thousand of these and considers it to be one of the most foundational labs that we could run. It's so far beyond just when you talk about hormones, people think of hormone replacement therapy. Oh, this is low or this is high. We need to treat the paper almost. So this is really getting into the nitty gritty. You said that on a couple slides there, really it can take a couple hours to go over it properly. Well, that's exactly what we do in the functional diagnostic nutrition course. We take our time, we go through each one, we explain the anatomy, the physiology, the biochemistry in easy to understand terms. And then you can go and do what we've done, help people, help. And I help thousands of people beginning with that foundational test because the catabolic to anabolic explains why they feel so lousy. People come in, they've been to 3 or 4, 6 or 8 or 10 different practitioners, tried all these different things, and nothing, or and nothing's worked. I was going to say, or they've been told nothing's wrong with you, because as you said in the very beginning, a lot of this doesn't really show up in standard blood work, and so they're left. What does that person do? They go down the street and they try this and they try that, and they're caught in a horrible and frustrating cycle of trial and error. And so this is one of the tests that we can use to put the brakes on this. No more cycle of trial and error. Let's figure out what's really going on. And people are elated to hear it. Now, we wouldn't exactly explain it like that to a client or a patient, but you'd give them enough of an understanding so that they would go, wow, wow, how come no one else run these labs? How come no one else figured it out? You figured me out. And when you hear that, it's very rewarding for a practitioner. You feel so good that you're actually truly serving a great purpose out there. And that's what FDN's all about. So I don't have much else to add to that, except for that if you want to learn how to run these labs and clinically apply them, in other words, get the clinical correlation, use the labs to explain exactly why your clients and patients feel the way they do and why they're so frustrated with all the other unhelpful
Well,
things that are out there.
I can't I can't say more that I agree. It's really quite something. Your group was really the first that recognized, and I want to send a bouquet out to your group. You're the first that recognized, because it goes back many years ago, that this test is seminal. You call it foundational. Why? Well, today we started to deal with that by saying, you think it's only the adrenals? You think
Mhm.
it's only the sex hormones? How often, Reed, do we hear someone saying, why are you doing sex hormones in saliva? Why don't you do it in urine? Well, here we are, and we're going to get there next time. On this one report, you've got a quick screen that says, how are they affecting each other? Oh, you want to hear more about the pathways? You want to know more about all of this? Sure, you do a urine test, like a 24-hour urine, etc. Of course, you can go into it more deeply. But here, in one fell swoop, it's there in front of you. No one can miss it. It's right there. And that is so powerful. It is so incredibly powerful. It's liberating in a way because
It
now you
is.
can see how they work together.
It's very emancipating, I call it, because
Yeah.
now you know why people are presenting the way they are when sort of no one else can figure it out, or their methodology is just to relieve the symptoms only, instead of giving them the all of the lifestyle and things they can do to take control of their health, which you spoke very admirably about. And guess what, folks? It's time to end this call. But remember, we've only gone over 2 of the markers on this amazing advanced stress and hormone profile. A couple more markers coming up at the next episode. So we hope you'll turn into the FDN Lab and Learn show if you want. And we'll see you next time. Thank you, Aaron.
It's my pleasure. Thanks, Reed, and see you guys soon.